Hello, good afternoon, everyone. I welcome you all for yet another session of Indian Fertility Society webinar series. So, for today's session, we are having Dr. Tanya Rohatgi with us, and she'll be talking on the topic OHSS prevention and troubleshooting. To talk about Dr. Tanya, she is MD FRCOG London, DFFP London, MSc Distinction in Reproduction and IVF, Bristol, UK. She is a principal consultant in IVF, reproductive medicine and surgery, and oncofertility, consultant training in high risk obstetrics and gynecology, IVF leads, teaching hospitals, NHS UK. So, with this, I hand over the session to Dr. Tanya. Ma'am, please continue with the session now.
So, namaskar and a very warm good afternoon and a happy new year to all my friends who are here. And yet another session. And I would like to start by thanking Professor Sudha Prasad and the IFS for giving me this platform, Guiders for having us here, and of course, DocMode for giving us the platform. So, we're going to talk about a very, very common and yet very pertinent topic, OHSS. So, what are the preventive steps we can take? And once it happens, is there anything we can do to troubleshoot and get a better outcome for the patient? So, as you know, we've been hearing about OHSS for centuries, and we think we've conquered it all. However, we're still not there yet. So, let's see, friends, what we can do to prevent severe OHSS. So at the outset, we'll be talking a bit about defining the condition, a little bit about pathogenesis, what is the incidence, the classification, some case scenarios, prevention, and to conclude. So by definition, it's mainly an iatrogenic systemic disease resulting from ovarian stimulation. It is dependent on HCG exposure, and we all know there are various factors, for example, interleukins and the VEGF, which have been known to be the culprits. We've got secondary mediators which are activated when this cascade gets going, so which include the renin-angiotensin system and the platelet-derived factors. Also, my dear friends, it can happen in spontaneous conceptions. So remember, always think OHSS. It's not only a condition with ovulation induction or IVF, it can happen in any pregnancy. So what happens with HCG? As you can see here, we've got the vasoactive substances. There's an increase in the vascular permeability. All the vessels become very leaky. There is increase in the VEGF levels. There's shift of fluid to the third space, and we've got the transudates which accumulate, leading to ascites, even hydrothorax, or even pericardial tamponades. There's a depletion of the intravascular volume, and there's hemoconcentration, and hence risk of thrombosis and clotting. So really, it's a mix of various factors. There is the overstimulation that happens. There's an over-response in some patients. We know the PCO patients. We know patients with the FSH receptor gene mutations. And then we have the HCG, be it in a spontaneous pregnancy, be it heightened because of multiple pregnancy, or because of its use either for the trigger or for the luteal support. And it most likely happens when all of them intermix together and coexist. So we know there's an element of an early OHSS, which happens because of the ovarian response and everything that we've used, and usually happens in the first 10 days. And then we have the late OHSS, which is once the pregnancy and the endogenous HCG is coming up. So just I'd like to take your attention here, my friends, is that if you look here in red and the yellow, which is what we're most scared about, which is the severe and the moderate OHSS, it is the late which is more likely to be severe. And often it's the late OHSS which is more difficult to predict from an ovarian response. Often we are very confident when we start off and we think, oh, this is just mild and the patient will be fine. And before we know, she's pregnant and she's landing up in a severe OHSS and is getting hospitalized. So right from something as simple as using clomiphene, which we all use, you can see mild OHSS ranges from 10 to 15%, moderate to about 8%. Usually severe OHSS is quite rare with clomiphene treatment. In gonadotropin cycles, as you can see, the ranges are much higher, and you can have severe OHSS. Anything ranging from 0.1 to 2% is usually the common, but some cases are reported as high as 10% in some cycles. What about IVF cycles? Again, it's very variable. This is a paper from 2002, quite way back. I think all of us are very mindful and very cautious when it comes to OHSS, but still, each of us have seen mild, very common, almost 1 in 3 cycles land up having a mild OHSS. Moderate is less than under 10%, and very rarely either the severe or the critical in less than 2% cases. What about the classification? We have mild OHSS. Often our patients will complain a little bit of pain, a little bit of bloating, and the ovarian size is less than 8 centimeters. When we go on to moderate, the patient starts feeling more sickly with either nausea and vomiting. As you can see, ultrasound now here starts picking up ascites, and the ovarian size is between 8 to 12 centimeters. In severe OHSS, you can see it's a clinical ascites. You can have even a hydrothorax. Patient can have symptoms of oliguria. In the lab parameters, we've got a hemoconcentrated blood parameters with a hematocrit more than 45%. There's hypoproteinemia, and the ovaries are quite large. And usually, you can even feel them up there. Critical is when there's tense ascites or very large hydrothorax. You can see hematocrit is more than 55. You've got a raised white cell count. You can even go up to anuria. You can have thromboembolism or ARDS. So really, in the host of complication, what we are worried about, it can be hepatorenal failure, ARDS. You can have ovarian torsion. You can have intra-abdominal hemorrhage, and even rarely you can have death. So we have to be very mindful that all these complications can happen. And if it's a severe or a critical condition, we can lose someone who really was a healthy patient to start with and came to us to have a child. So I think we have to be very clear how we want to get our patients to get pregnant and what is the outcome truly that they are looking for. So in the workup, always remember it's your patient's clinical symptoms which will guide you best. Does she have pain? Where is the pain? How bad is the pain? Is she breathless? Does she look dehydrated? Does she look fine to you? Is she saying she's quite thirsty? What is her weight? Look at her vitals. Look at her abdominal girth and look at her distension. Does she have ascites? Then comes the host of investigation, which will be obviously tailored to what we see in the patient. Now, looking at a case, so we had a young 25-year-old lean patient who was a non-hirsute PCOD with oligospermia. The parameters in the hormone were fine. As you can see, the EMH was high at 6. The tubes were fine. The insulin, testosterone, sugars were fine. Because of the mild male factor and subfertility of 2 years, she was planned for an IUI. Now, in the past history, this lady had a previous cycle with clomiphene of 50. She did not respond. They went up to 100 with 75 of FMG on day 5 and still 7. There was no response. So finally planned on a step-up gonadotropin protocol. Started with a 75. Started with a 75. There was no response after 7 days. Dose was increased to 150. After 5 days, again, the response seemed not very optimal. Dose was increased to 225. 4 days later, boom, that's what we see. 6 dominant follicles are there, and there is free fluid. Patient starts complaining. She's not feeling very well. Now, what are the options in front of us? Cancel the IUI cycle. But I think what we have to be mindful, often what we think is canceling the IUI, not giving a trigger, and we end up telling the patients you can have sex, but that is not the idea here. If we are canceling, the whole idea is if you're that worried, the question is, should she get pregnant? So it's not just canceling the IUI, it's about not having a pregnancy in this current cycle. Can we convert it into an IVF cycle as a rescue cycle? What about hosting? What about follicular aspiration? These were things which were done in the past. So let's see what happened with the patient. As you can see with the blood work, her estradiol was 2500. The rest of the parameters were fine. Her CBC, her hematocrit, coagulation, liver function, kidney function was all fine, except she'd now started complaining of pain, nausea, she was bloated, she wasn't feeling very well. So this was actually one of the patients who was initially prepped by one of our general gynecology colleagues. And then this patient started complaining, very, very clever. The gynecologist looked at her, said she doesn't look right. There is a risk of hyperstimulation. She handed her over to us after looking at the patient, counseling her with the options, telling her about what OHSS is and being a real risk. We converted into an IVF cycle. We froze her embryos. And 6 weeks later, when the ovaries came back to normal, she was absolutely fine. A frozen cycle was done for her, and she delivered a healthy girl. So, definitely a viable option. But the question is, please think about it and think of all the options that are there, which are presented to you in your unit. So, just to go up, we know I don't have time here, but we'll talk about low dose step up stimulation, usually best for the PCOS patients. Again, we need to know that it's the mild stimulation. You don't want too many follicles. A, you don't want to have very high estrogen levels. B, at the same time, you want a singleton pregnancy. So usually the starting dose 37.5 to 50. Often here, when I trained in England, we have used doses as low as 37.5. But honestly here, if I'm worried, I start with a 50. In our patient, we started with 75. But I think what is more important is that don't jump the doses very frequently and very high. I think the patient and the doctor both have to maintain their patience. And if you have to go up on the dose, do it after 7 days and with an increment of 37.5. If you look here between the conventional versus the low dose step up protocol, the pregnancy rates are similar, but you can see that there is a much lower risk of ovarian hyperstimulation. So what about rescue IVF? This was a very good paper, and they found that this option had a lower cost per cycle relative to cycle cancellation and conventional IVF. And they actually found that it was quite good, and the implantation and ongoing pregnancy rates were higher than those when they compared it with the hyperresponder of the regular IVF patients. So definitely, if you have links with an IVF unit, and if this is a possibility, please do consider rescue IVF in cases where either there's a hyperresponse or there is an element of OHSS which is setting in, and you want that for the best of the patient, she shouldn't get pregnant in that cycle, so we can salvage the current cycle as well. We know that there is an option of canceling, but it's not just the finances sometimes. There's a lot of emotional burden that the patients go through, so we have to know what else to offer. So we're talking about primary prevention, where we are going to think about the risk factors and be mindful of them. What about secondary prevention? If it has happened, how do we limit the severity and we don't reach the severe or the critical stage? So in primary prevention, again, I would say always think OHSS. Anyone who can get pregnant can get OHSS. Recognize the risk factors, tailor your individual stimulation protocols. There's a whole lot of guidance out there. We have things like the consort study. There are protocols, there are pathways, depending on the age, on the BMI, on the previous history. How do you start the gonadotropin? Make your own protocol. Monitor, and as I will say that again, it is not always the investigations, the estradiol or the ultrasound. Please remember, it's your patient first. So what the clinical parameters are, how your patient is, would deem as the best marker to prevent a severe or a critical OHSS from setting in. So moving on here, a very nice review, which was done by Busso et al. In 2010. And they looked at what were the risk factors. Obviously, we know if it's a young, it's a lean patient. So the young, thin PCO are the most scary ones. Then you've got allergy here. And very interesting, blood group A were the ones found to be more at risk for PCOS. If you're going to do the stimulation, what they found is that if you have more than 35 follicles with the conventional stimulation or more than 6 in the ovarian ovulation induction, high estradiol levels, they took a cutoff of 4,000 or 1,700 in ovulation induction, conception cycles, use of HCG for the luteal supplementation, or where you have the provision of monitoring the VEGF levels. So I'm just going to take you through certain cases, which again, I want you to take back, always think OHSS. This was a paper to 2020 by Dr. Neeta Singh from All India Institute in Delhi. And as you can see, very surprisingly, there's a severe early onset OHSS with liver dysfunction in an IVF segmentation cycle. So we think that if we're going to use the approach initially set by Professor Paul Devroy, whereby you've got an antagonist cycle, you've got the agonist trigger, and you're going to freeze all, that you're quite safe. But again, think, my friends, so this was a cycle, a young patient with PCOS who had a previous cycle where she had early onset OHSS. So again, risk factors, someone who's had it before, much higher risk of having it again. And as you can see here, they followed everything to the T. It was an antagonist cycle, it was an agonist trigger, it was a freeze-all approach. And despite the fact they didn't use any HCG, she developed severe OHSS with markedly deranged liver functions. So again, always think OHSS. This is a case, very interesting, again, 2020, which I want to highlight. These are not cases which are from 2010, 2012, very recent in 2020, and these are severe cases which should not happen today. So this was a case where, again, there was hyperstimulation in a post-toward embryo transfer cycle, something rare but can happen again. We tend to think in HRT and in a frozen cycle, OHSS doesn't happen, but it can happen. So what was the key learning here? That the patient had an HRT cycle, frozen transfer with blastocyst. However, they transferred to blastocyst, and because of multifetal pregnancy and the high HCG levels, patient had OHSS. So what they've said, always promptly recognize the OHSS, and in this case, they actually had a fetal reduction, and they came to a singleton pregnancy, and the pregnancy was uneventful post that. So this is a paper that I have presented, actually very interesting, came as a shocker for us. 2017, a spontaneous OHSS. This was a young girl, PCOS again, but she had abnormal lipids, abnormal sugars. She was already on metformin, and we thought that it couldn't be OHSS, but when we investigated her, she was found to be hypothyroid. And now we do know that there is a subspect of spontaneous OHSS, which is linked with hypothyroid patients. So once we corrected that, she had an eventful pregnancy. But remember, again, it can happen. Also think of your thyroid while you're thinking OHSS. So estradiol, sometimes we think it's the be-all, end-all. It's actually not a reliable test at all. It can happen at any cutoff. It can even happen with low estradiol levels. So don't reassure yourselves. And secondly, what I'd like to say is don't rely just on one value. If you see here, if you're going to see a very sharp rise of estradiol as well, so let's say you've done estradiol today and you repeated 24 or 48 hours later, and there's a doubling, and it's really going up fast, and think this is a person who can go into OHSS very soon. Again, the recommendations vary. As I said, someone said 1700. This is a paper by Levy. They've said to cancel at a level more than 1800. However, remember, it can happen at even low levels. So really develop your own SOP, develop your own protocol. AMH, definitely better protector and predictor of OHSS. And we do know that, again, different cutoffs here, but this Lee gave a cutoff of 3.36 with a very good sensitivity of 90%. And as you can see, they've compared it with both the age and with the BMI. And as you can see, AMH is doing much better. So they also looked at secondary prevention at the various modalities, and what was very good, they looked at the levels of evidence. Is there a level of evidence A? Is it a level of evidence B? Is it a level of evidence C? So metformin came as a good measure with a level A evidence, definitely lower starting dose of FSH in patients who've been cancelled for an over-response, a level A evidence. You've got an antagonist cycle, which is a level A. Interestingly, lowest effective dose of HCG. Now, again, we still have, and all of us, have used 10,000 because we tend to believe 10,000 is a better dose, but we do know 5,000 is as good, or even a 250 of ref HCG. It's all the same. If you're going to use HCG, there's a risk of OHSS. So we have to be mindful of that. Whether you use even a 2000 dose, it can happen. And it doesn't matter whether you're going to use a recombinant or you're going to use a urinary. Coasting is a level B evidence. I'll speak about coasting in a moment. What about dopamine agonist? So we have kebagoline. I'll speak about that in a moment. Obviously, we've talked about the segmentation approach and a freeze all. What is interesting is they did look at what does not work. And I think that's important for us to take back, is because when we're featured with such patients, we are now thinking, let's use everything. So intravenous albumin level A evidence did not work. Follicular aspiration did not work. Using REC LH instead of HCG did not work. Using REC HCG instead of urinary is not working. And using one type of FSH to the other. So if you think you're going to use the urinary or the recombinant, it's the same. And again, all level A evidence. So again, ASRM, very nice paper. This was a practice committee opinion in 2016. They came up with a list of risk factors here again, and they looked at them with a little bit of a caution that while the cutoffs require validation, they all were grade B evidence. AMH values more than 3.4, AFC more than 24. When they compared with AFC less than 24, there's a huge difference, almost 2.3 to 8.6%. Development of follicles, which are more than equal to 25, or having more than 19 large or medium-sized follicles before HCG. Estradiol levels for them, they took the cutoff of 3,500 and more than equal to 25 oocytes retrieved. They came up with their list of recommendations as well. So, of course, again, GnRH antagonist is the way forward. That is the protocol level grade A evidence. You've got the agonist to trigger the final oocyte maturation, grade A evidence. You've got dopamine agonist, again, a grade A evidence. And they looked at additional strategies. And what is interesting, that apart from metformin, they looked at aspirin and they looked at cryopreservation of embryos. Although there are not many studies with aspirin, they still do recommend. This is a grade B recommendation. So coasting, this is a very nice paper which Velasco looked at coasting, and they looked at it when the estradiol levels were more than 4,500 or more than 150 picogram of estradiol production per follicle. What is important to know is that you started when the follicle is about 16. If you start it very early or very late, it's not going to work. It's really going to ruin the cycle. When you've got follicles between 15 and 30, very important, you then have to be very strict with your estradiol monitoring. Monitor it on a daily basis. What you don't want is too many highs and lows or a sudden drop. So what they then said is that you could either give the HCG 5,000 or the agonist trigger. And when the estradiol levels, according to them, came down to under 3,500. They said abandon the cycle if your estradiol is still rising, it's more than 6,500, you've got more than 30 mature follicles, or the coasting has taken more than 4 days. Now, usually most of us are not coasting, but if you had to coast, a day or two is okay. Anything more than 3 days usually does affect the outcome. Trigger, we've spoken, we're looking at an agonist trigger. We're saying HCG definitely is increasing the risks. And there's one study which said that any form of OHSS goes up almost by 4 times the risk, and of moderate to severe OHSS of about 1.35 times versus the agonist trigger. Again, I'd reiterate, it doesn't matter what HCG you use, either recombinant or urinary or reducing dose of HCG. So Smith et al. Looked at 10,000, 5,000, 3,300. Recombinant LH, some people have used it, but again, because of the cost and the pregnancy rates were not great, it's not recommended. So as you can see with the GnRH agonist, you see the compare the two with the VEGF expressions, GnRH does much better. Now again, look at the recovery rates, and there's not much difference between 5,000 and 10,000. So please use the lowest effective dose. Kebagoline, so we're talking about the dopamine D2 receptor agonist. It does reduce the risk of OHSS, especially for moderate OHSS. And recently, the Cochrane did look at the cabergoline pregnancies, and they found that it did not affect the outcome of pregnancies or the miscarriage rate. So zero point 0.5 milligrams starting on the day of HCG injection and use it for 8 days. Bromocriptine, this is a paper very much from Delhi, Dr. Sonia Malik. And what she found that sometimes because of side effects of cabergoline, patients are not able to use it. They're anyway feeling sticky and they're wanting to vomit all the time. And then you give them cabergoline, which often causes a lot of nausea by itself. So they used bromocriptine and they used 2.5 milligram per rectally for 16 days from the day of OPU. And they found reduced moderate OHSS and hospital admissions. And they actually achieved fresh embryo transfer in their cases. So again, very nice paper. And as you can see here, what is important to be mindful is that it is causing a benefit in the ascites and in the moderate OHSS, but not in the severe OHSS. So it does help, but more so with the moderate cases. And as you can see here, not much of a difference whether we're looking at hematocrits more than 45, rising creatinine, or higher level of the liver enzymes. Again, here, this is the forest plot. You can see definitely in favor for moderate OHSS, and it reduces that risk. Metformin, again, a lot of our patients are already on metformin. Some people specifically use metformin for reducing OHSS. Now, this was a paper in 2006 where they gave metformin 2 months prior, and they found that it reduced the risk of severe OHSS. So here, as you can see, it is definitely reviewed, and the reduction with OHSS favors the use of metformin over the placebo. Now, there are a whole lot of studies, not many actually in terms of numbers. This paper by Tommy Tang in 2005 was done at my unit at Leeds. And obviously, this was not our primary aim, but when we found out the benefit, it was very interesting that metformin can have various benefits, not just on insulin resistance. So now what about colloids? Should you have the HES? Should you have the albumin? So again, what is the key thinking behind is that you want to increase the plasma oncotic pressure, hence have more of the fluid in the intravascular compartment rather than the leaky vessels. So Faisal et al. Found actually a lack of evidence to support benefit from the use of albumin, and at the same time found a decrease in the pregnancy rates. So you've got to be very mindful, do not use albumin in everybody. Albumin is sometimes used when the patient is either persistently hemoconcentrated or has oliguria, and at times albumin is combined with even dopamine, especially if we're worried about the kidneys. What about HES? It's a non-biological agent. It's got higher molecular weight than albumin. It's cheap, it's easily available, and it's a safer option. After all, albumin is a blood product, and there are risks of either having a viral transmission or even allergies or anaphylaxis with albumin. Calcium gluconate, a very good paper, again from India, and seems quite effective. Even the ASRM talks about it. So a 10 ml of 10% calcium gluconate in 200 ml of physiological saline within 30 minutes of woman pickup, and then you repeat it day 1, day 2, day 3 post pickup. And what it does is works through the renin-angiotensin system, and because of that, the VEGF levels is definitely ameliorated, and it found a very good effect. And some studies have compared it to cabergoline in OHSS prevention. What about letrozole? Something very interesting. This is a paper where they looked at, again, recently, 2020, and they found that letrozole could have a potential use for OHSS. And this review looked at the incidence of moderate and severe OHSS and did find a decrease in the incidence with letrozole use post-pickup. As you can see here, a lot of studies right from 2014 to 17, and it favors the use of letrozole. But we've got to be mindful. There were many limitations of this review. First of all, there was a lot of heterogeneity. Some were prospective, some were retrospective studies. There were different types of treatments done here. There were different doses of letrozole, someone using 2.5, someone using 5, some even 7.5. Now, there were different treatments. Some were adding letrozole along with HES, some had aspirin, some had calcium, and some had nothing. The sample sizes were pretty small, and there were quite a few confounders as well. So, letrozole at the moment should not be considered as first line treatment. Potentially, we could use it maybe as an add on, but not just the sole treatment. What about misoprostol? Something very interesting when I looked at this paper, and I thought that really it's something we can use, and especially for our donors, because we're so used to using misoprostol, and especially intravaginal misoprostol works really well. So what they found, they gave post pickup the 800 micrograms of misoprostol, and they concluded that intravaginal administration of misoprostol coupled with a freeze-all approach avoids the OHSS during the luteal phase in the IVF cycle. So what they did, they gave the first dose, and 48 hours later, they reviewed the patient. If she was not better, they repeated another dose, and they did find a very good improvement. So a little bit about aspirin. So there are various studies. As I said, the SRM looked at it in a bit. And this is one paper where they've used the aspirin along with steroids. And they've given a daily dose of 100 from the day of stimulation right till the end. Either she has a positive or a negative cycle with the prednisolone in various doses. And they found a lower incidence of severe OHSS. So there are studies, both pros and against the steroids. Some have said it is effective, some have said it's not effective. I think, again, we've got to take it with a pinch of salt and not use it on all our patients. So something, again, very recent and something which may be another adjunct which comes up. So diosmin, so it's a flavonoid, and what they used, again in this paper, they compared diosmin to cabergoline, and they found that actually diosmin was more effective in preventing severe OHSS rather than cabergoline in high-risk patients. And they used a dose of 500 twice a day, and again from their pickup for up to 2 weeks. So again, we have to find our own best treatment policy and see what all you want to add in your basket and how you want to troubleshoot. What about others? And I think if you're going ahead and considering that you may want to do a fresh cycle, the patient is not too bad, there's a little bit of mild OHSS, think of a blastocyst transfer, obviously a single blastocyst transfer. Why? Because you get a 5 days observation period. If she's still not well by the time you're up to the blastocyst stage, then freeze, don't transfer. Obviously better to be safe than sorry. And we want to have a singleton pregnancy because, as I've highlighted, if you have multiple pregnancies, then there is a higher chance of having severe OHSS or even moderate OHSS. So just finishing up, what are the new insights that we have? We've got the COX-2 inhibitors coming up, we've got in animal models, suggest a positive role. We've got the vasopressin 1A receptor antagonist, levocorbactin, and shown some benefit. One study I found, doxycycline, we found tetracycline inhibit angiogenesis and actually prevent the VEGF-induced vascular permeability. So maybe something you can consider as well. IVM is a technique where people have used in PCOS patients where we retrieve the immature follicles and mature them in the lab. So rather than waiting for the follicles to reach maturity, 18-20 millimeters, the eggs are picked out at an immature stage. So when the follicles are still small, 10 to 12 millimeters, and then in lab we're growing them. But you've got to be very clear that your lab is capable of having good pregnancy rates with IVM. It is not the norm, and not everybody has good results. So I think it's something which we still have to wait and watch. Kisspeptin seems to be the next future, and there are studies suggesting it's more natural and actually it will be the future of IVF. But let's see how that goes forward and what would become the norm in the next few years. So really, to conclude, always think OHSS, risk factors. Anybody can have OHSS. Anyone who's going to conceive is at a risk. But please Make a stratification, look at your risk factors, look at each patient differently, tailor your protocol, see which is the best for your patient. We want all our patients to be pregnant, but we obviously want all of them to be safe as well. You've got the secondary preventive steps. I've listed a whole lot of them. You've got to see what works for you, be it cabergoline, be it metformin, be it using HES, be it aspirin. Maybe do you want to consider using things like diosmin, or you want to have letrozole, or do you want to add in tetracyclines? Think. Segmentation approach does not mean 100% safety, but it's as good as it gets. And with all of us now, we've got very good freezing protocols. We've got very good successes with the FET cycles. So it is not something we should hesitate in taking up as a primary approach. Prevention is the best treatment. Always think. And I think the first step is plan your patient for a safe pregnancy, and we will be able to limit the severe and the critical OHSS, which shouldn't happen. If it does happen as a rarity of the cases that I've shown to you, even in 2020, especially with the COVID era, we have to be mindful of how we are going to save these young patients and how we can eventually limit the secondary complications to make sure the patient is safe and the patient goes home safely. Thank you very much.
Yes, ma'am. We can begin with the question and answer section now.
Okay. So there's a question from Mumbai, Dr. Kalyan, asking any complicated case which, apart from the ones I've shared, actually, yes, when I was in England, there was a case of OHSS where there was an intra-abdominal bleed. And it was very scary. It was one of the first few cases, actually, when I started off as a fellow in the IVF department. And we had to go ahead, and she needed a surgery because there was a torsion as well and there was a bleed as well. What we did was a conservative approach. We were able to save the patient and the ovary, but it was very scary. So there are, and these are real complications, because the abdomen was full of blood. We had 2 liters of blood from the twisted, torted ovary. And what is very important to remember, these are not easy cases to even to put the laparoscope in. You've got these large ovaries, and when you're going to do the laparoscopy, you've got to be very careful not to puncture the enlarged ovaries. So go a bit higher, be safe, and have all your precautions, have the ICU there. So we were able to save the patient, but it was quite scary. There's a question about any new diagnosis of OHSS. So there's actually something very interesting with the spontaneous OHSS. As I told you, one of my patients had spontaneous OHSS, and initially it was very difficult to even get to the diagnosis and tell myself that, yes, this is OHSS, because really she was just a PCO patient with nothing else going on. And we had used nothing in the patient. She was already on metformin, and you think that she should be fine. But in that, we found out that because her thyroid was quite deranged, and when I did look at a subclassification, so for the spontaneous, there are 3 groups. The type 1 is where you usually have the FSH mutations, and you can have a recurrence of the OHSS, so be mindful of that. Then you have the type 2, which is usually linked with HCG and the multiple gestations. And the type 3 is what, like my patient was, with the hypothyroid. There's a question about management, so fluid balance. And I think, again, we have to see, is it a mild, is it a moderate or a severe? So you have to make sure that your input output is very carefully charted. You usually tell the patient to drink to thirst. So what you don't want is to put tons and tons of fluid in her where she has leaky vessels and all the fluid is coming out. What you're going to use is something very carefully. And I do, at the time of pickup, I use HES, and I've usually got very good results. Very occasionally, I've used albumin. So I've had a patient as well who did land up going into the ICU, and we needed to use albumin. So we were using two every 6 to 8 hours. And at the same time, she was having her aesthetic tap being done, crystalloids being used. So RL is what I was using. And we were maintaining her urine output. So whenever there's fluid that you're putting in, you have to make sure that your output and your use and ease are very, very carefully monitored. You have to be very careful about your potassium levels as well. So remember, this is then going to be an MDT approach where you've got yourself, the ICU team, working very close to each other. What I also have learned is that once they reach our medical colleagues and our friends, you have to be the person leading it with your protocol. Otherwise, they get scared, and before you know, is that the first thing is they're being given diuretics, and they're being, you've already got a very compromised intravascular space, and that's further going to reduce. So if you've got to use the diuretics, very, very careful. And at times you've got to even use dopamine. So for that, you've got to make sure you're carefully managing every aspect of the organ, because we know it can ultimately lead to a multi-organ failure. So there's one more question, is a little bit about, again, ascites, effusions, dyspnea. So all related really, yes, because we've got the vascular space, which is very leaky. You can have fluid going in anywhere. It's not just the abdomen. It can go in, and you can have effusion in the lung. You can have it around the heart. See what the patient is presenting. Is it only breathlessness? How is she? Is it also a lot of dyspnea along with cardiac symptoms, which is there? Is she able to even complete a sentence? What is her saturations? Then you look at all your investigations. Sometimes you even have to have a cardiac echo being done, and then we've got to manage the fluid accordingly. And the dyspnea, it could be because not just because of the effusion, but also because of the enlarged ovaries. Imagine everything is being pushed up. They're uncomfortable. They can't lie flat. So often they're happier if you prop them up a bit. There's also a question about advances in treatment. And I think the best advancement is not having to have a patient reach the critical or the severe stage. And as I've said, there are multiple things which are there which you can put into your kitty. And there's something that I use if I'm worried, is you can use the antagonist post pickup, and you use it for a few days. So what we are really trying to do is cause very early luteolysis, get a drop in the estradiol level, and at the same time, you want to bring down these enlarged ovaries. Keep an eye on your patients and see what all you can do. So whether we're going to, as in, use the letrozole, the antagonist, the diosmin, the cabergoline, you pick up what works best for you. Honestly, I have used a lot of cabergoline, and at times the patients cannot tolerate for even the 8 days. So I have started with cabergoline and then moved on to using bromocriptine along with the antagonist. I haven't used diosmin. And there's one more question about the white cell count, and can this be considered as a considerate view to monitor OHSS? Yes. So remember, when we were looking through the parameters, and one of the blood parameters for severe and critical is that your white cell count starts to go up. Your coagulation changes, your D-dimers change, and your white cells are going up. Now, what is important to know is, again, this is like a whole lot of inflammation which is happening up there. Often we get scared, and we have to monitor all the parameters together. So it is not just one parameter. You've got to look at your hematocrit. You've got to look at your sodium, your potassium. You've got to look at your white cell counts. You've got to look at your platelets. You've got to look at everything in totality to see how your ranges are. But trust me, in a couple of days, it does tend to settle down. And if it doesn't, then we have to be more and more aggressive in our management. We have to make sure that we are doing tapping and we are getting the effusions to be out. And as I said, in my patient, which was admitted to the ICU, she needed almost 3 days of we were tapping and we were tapping. We were putting in the albumin for her, and she did well eventually. She was in the ICU for 4 days, then shifted to a room, and then she was back home. So it is a combination of factors, and white cells do change. So for example, if you started with a count of 14, 15,000 and suddenly it's become 25,000 and then 45,000, it's getting worse. So each patient teaches you what your ranges are. Now, often what happens is that we know that while you're doing all of these tests, you find out she's pregnant. And these parameters are different in pregnancy as well. You know, the white cell count changes in pregnancy as well. So you've got to take that into account with what the levels are. So we should look at the trend, we should look at the changes rather than singular values. If the value is on a betterment or if our trend is towards a worse, sometimes we have to repeat the bloods a couple of hours. So you can land up doing them either 6 hourly, 8 hourly, or if the patient is becoming better, it can then move to daily, then it can be moved to 48 hours, 72 hours, till you're confident that the patient is fine. There are no more questions.
Yes, ma'am. I think we are done with the questions now. I'll request you for a short takeaway message for the viewers.
So I think what I'd like to say is that please think that OHSS is still very much there, even in 2021. It's not faded away completely. We have managed to conquer it to a really great extent. And I must say that it is all the effort by all my clinician friends as well, that we want the best outcome for our patients. At the same time, that don't get scared. If it happens to all of us, and we should just know how to collaborate all our knowledge to get the best outcome for the patient. And if she has landed up in OHSS, I think the key here is how do we prevent it from becoming severe or critical. You save the patient first. That is your primary outcome. In some cases, there have been reports where they have to actually terminate the pregnancy as well to save the patient. So look at your patient. Please, when you are starting a stimulation, optimize the stimulation. You know, we all tend to think if we have too many eggs, we can have a great outcome, because if it doesn't happen in the first cycle, we have few attempts at the frozen cycle. But please, I think we all know, we've seen a correlation between the number of eggs to the live birth rate. And there's no point taking out 30, 40 eggs, even if it's a donor. So be mindful of how you pick up a protocol to stimulate your individual patient. If it does happen, there is ways and means to control it. Safety is really the first and the foremost. Thank you very much.